I want to welcome our esteemed guests tonight and also dear colleagues and all protocols observed. It gives me great pleasure to have the opportunity to give a brief presentation tonight on the changing health needs in complex emergencies. As you are all well aware, there's a major global crisis in terms of the large numbers of refugees and internally displaced individuals. And it's estimated that by the end of 2014, there were an estimated 55 million people around the world who fit into both of these categories, either of these categories as refugees or internally displaced individuals. And as you can see sort of from this map here, in the blue for the refugees and in the pink for internally displaced individuals, persons, that the clusters of the large numbers of these individuals that are in this region, largely in the Middle East, Turkey, Southern European region, and Sub-Saharan Africa, and you can see a similar focus here in terms of the region we're talking about today. Now, when we look at the major refugee source countries and host countries, in this figure on the left side, the major refugee hosting countries, and certainly Turkey is a major hosting country, as we've heard today. It's it's quite amazing and impressive to actually note and acknowledge the accomplishments by Turkey and its welcoming of such a large number of displaced peoples. It's something that's pretty unique and historic. But as you can see, there are also several countries around the world similarly have large numbers of refugees, including Pakistan and Lebanon and Iran and others, as you can see here on the left. On the right, you'll see the numbers of refugees per 100,000 inhabitants, per thousand, sorry, thank you, inhabitants. And obviously, we know that Lebanon, on the other hand, has really borne an enormous burden in terms of welcoming refugees. And you see it has a huge number, 232 individuals per 1,000 inhabitants, which is rather remarkable as well. I think I need technical assistance. I'm not an Apple person, so Apple computer. How do I go next? Okay. So what are the challenges in terms of the health challenges of refugees in the 21st century? What are the challenges today? I'd like to focus on three factors that really characterize the refugees of this century. And they are the following three factors. One is chronicity. And the fact is that displacement now is lasting for many years, sometimes even decades. So refugees are no more displaced for discrete, short periods of time. Secondly is the diverse displaced populations. So we're seeing more and more displaced individuals who are coming from middle-income countries, and this is something new and expanding, versus traditionally in the past, they've come usually from low-income countries. And then thirdly is the whole issue of urbanization, where the majority of displaced people are now not located in refugee camps. As we know, I've heard in Turkey, for example, I'm told that only about 20% of the refugees, the Syrian refugees, are in camps, and the vast majority are in urban settings. So these three factors are very important, and they change the architecture of what we need to do to respond to the needs of refugees today. So let's talk first very briefly about chronicity. So we have a situation now where there's what's called protracted refugee situations. And in brief, these are situations in which refugees have been in exile for 5 or more years, and without any immediate prospects or for implementation of a durable solution and return to their countries of origin. It's estimated that 75% of refugees currently are living in protracted refugee situations, meaning they've been in these settings for 5 or more years. And UNHCR estimates that the average length of major protracted refugee situations increased from 9 years in 1993 to 17 years by the end of 2003. And you can see, of course, with the protracted situation of Syrian refugees now, is that this is likely to also, unfortunately, continue and for a long period of time. And lastly, just a quote from UNHCR that refugees find themselves in a long-lasting and intractable state of limbo. Their lives may not be at risk, but their basic rights and essential economic, social, and psychosocial needs remain unfulfilled after years in exile. So if we look at this map, it shows there are 39 protracted refugee situations in early 2014. You can see where they are around the world and the size of the bubble, the sizes of these displaced refugees. And this does not include the Syrians that are displaced by the current civil war that started in 2011. So we have globally much more prevailing situation of refugees that are in a protracted state, in a state of what we're calling chronicity. So what are the implications of chronicity or protracted displacement? I think one, of course, importantly, is as people stay longer, their needs evolve. They evolve from emergency needs, humanitarian response, to longer-term development needs. So the health issues they suffer from are likely to reflect both acute as well as chronic conditions. In addition, they may require engagement of a broader range of stakeholders, including civil society and other stakeholders as well. And then, of course, because they're there for a long time and they have these multiplicity of needs, is the need for displaced people themselves to play an important role for them in their own livelihood and in their own health and well-being. And we saw an example of this, of the proposal now for the Syrian healthcare workers to be engaged in taking care of Syrian refugees. And then these raises important questions arise with regards to the effect of these refugee health needs on the host countries themselves. So with staying for a long period of time, there are issues that arise that go beyond staying for a few months that impact on the host country, like Turkey in this context, in terms of whether to integrate these individuals into their regular health systems or to develop parallel health systems. And of course, the whole issue of the implications of the ongoing need for more and more resources. Now, the second factor that I'm going to highlight today that I think changes the architecture of the needs of refugees in this day today are the diverse displaced populations, as I mentioned briefly before. So if you look at this figure, and this is from a paper from 2010, it shows that over time, the change in terms of the countries of origin from which refugees are coming from. And here in this figure, you can see at the x-axis at the bottom here, the years, and then the y-axis are the numbers of refugees. And you can see that in the light, I guess, what is it, greenish? Yeah, greenish color, yellowish green color, are those the proportion that are coming from, the numbers that are coming from medium and high income from countries with high and medium income development status index category versus those in blue that are from low income countries in general. And you can see that over time, a bigger and bigger proportion are coming from countries that are more of middle and high income countries that are in the category of middle and high income countries overall. So this is a huge change over time that we're seeing around the world. And then if you look then, what are the implications? Because now more and more refugees are coming from middle and higher income countries. And of course, in those countries, we're also seeing at the same time a transition to the important issues of non-communicable diseases as a predominant cause of morbidity and mortality. So you can see in this figure here on the y-axis a percentage of total death that are caused by non-communicable diseases. And then on the x-axis are different countries, starting from the left, Syria, Afghanistan, Somalia, Sudan, South Sudan, DRC, Myanmar, Central African Republic, Iraq, and Eritrea. And you can see that in these countries, actually non-communicable diseases are responsible for a substantial proportion of death. So it means that the refugees that are coming from these countries also are coming from countries where non-communicable diseases are a predominant cause of morbidity and mortality. So they bring their risk factors and they bring the risk for such conditions with them. And this is quite different from the traditional refugees that came from low-income countries where these conditions are, these non-communicable diseases are not as prominent as a cause of death. So just to summarize in terms of the impact of diverse displaced populations, as I mentioned, increasingly refugees are coming from these middle-income countries where chronic and non-communicable diseases are highly prevalent. For example, it's important to note that the leading cause of death in Syria before the war was cardiovascular disease. That's very important, which means then that for Syrian refugees, they will obviously have the same risk for such conditions like cardiovascular disease. And then, of course, as displacement is ongoing and exile lengthens, the need for non-communicable disease management and risk management grows. And this means not just, I think, curative services in terms of management of chronic disease, but also thinking about the risk factors for non-communicable disease, meaning the importance of prevention of non-communicable disease, smoking, overweight, obesity, and then the management, of course, of conditions like diabetes, cardiovascular disease, and mental health, which are very important non-communicable diseases that many of these new types of refugees are suffering from. So these are needs that arise in addition to the traditional needs. The traditional needs don't go away. These are added needs that are now prominent in this new generation of refugees. And the traditional needs include, of course, the importance of shelter, sanitation, safe water, food and nutrition, maternal child health, and prevention and management of communicable diseases. This is an interesting study that is actually from the US and demonstrates how the changing kind of risk factors for different kinds of conditions. And in this study, they looked at cardiovascular risk factors among Somali immigrants in the US. And these are actually, Somalia is a very poor country. Nonetheless, over time, when they compared in the US, the Somalis versus non-Somali population, and if you look at the adjusted risk for cardiovascular disease, you can see that the Somalis had, comparing them to non-Somalis in the same community in the US, had substantial rates of diabetes, pre-diabetes, as well as obesity, and also dyslipidemia as well. But clearly, the most prominent risk factors were for diabetes, pre-diabetes, and for either diabetes or pre-diabetes. So this means that even populations, as they move, and they stay longer, they also become at risk for some of these non-communicable diseases. So what about the third factor? The third factor that impacts on the health needs of refugees in this day and age is urbanization. And as I mentioned before, substantial proportion, it's estimated that only a third of the world's 10.5 million refugees now live in camps. And approximately, as was mentioned, 89% of Syrian refugees in the Middle East and Turkey live in local host communities. And I'm told, like, for example, in Lebanon, as one example, none of the Syrian refugees live in camps. They actually are no camps. So it's really the predominant challenge now is how to take care of refugees in the context of urban settings where they're integrated into the host communities completely. And of course, this vastly complicates the provision of health services because it needs to be linked to whatever the health services that exist within the host country and that exists for the populations of the host country. You can see here in this figure again, similarly over time, change over time, and the number of refugees in the y-axis. And in the blue are the numbers that are in camps. And then over time, you can see the increasing numbers of refugees that are in urban or non-camp, essentially in non-camp settings. So this tells you that, again, we're seeing more and more refugees globally that are in non-camp conditions or settings. So the reality is there's a growing need for continuity, prevention, and care for those reasons. And I think the reasons are, again, to some, the displacements for many years that I mentioned, the new health needs that have been identified because of the risk factors and the morbidities that exist in the source countries where the refugees are coming from. There are multiple urgent and competing priorities, and then accessing health service in contexts where care for chronic illness may be limited. And this is certainly in some host countries, although I know that Turkey, for example, does have quite a robust system for managing non-communicable diseases. But nonetheless, doesn't exist everywhere. So what does this mean? It compels us to think about what are the prevention priorities, how can we prevent, how can we work with the populations to prevent them from coming down with these conditions? What are the new models of care that are necessary to tackle chronic diseases versus acute conditions? They're very different. And in managing chronic disease, one needs to conceptualize of a health system that is quite different from trying to respond to acute needs that can be taken care of in one visit and one encounter with a healthcare worker. And there needs to be also new coalitions that are formed in order to respond to these new needs. Also, the healthcare workers need to have new skills. I think taking care of individuals beyond the cultural and linguistic needs, there also are different skills that are required to do preventive interventions as well as to provide continuity care. And lastly, of course, there needs to be a new policy framework that prioritizes the system for these kinds of needs. So I'll tell you a little bit about us at ICAP, as well as about the program for forced migration and health. Let me start a bit about ICAP at Columbia University. This is a center where I'm situated, and all of these programs are situated at the Mailman School of Public Health, which is at Columbia University. So ICAP was founded about a decade ago, and largely to focus on confronting major global health threats, and largely through strengthening of health systems around the world. And our work is really in partnership with ministries of health and other partners in the countries where we work to support program design, program implementation, training, mentorship, as well as research. And now we work in about 21 countries around the world. And we've had extensive experience over the years in trying to design, implement such programs, both to address infectious as well as non-communicable and chronic diseases, with a focus on sort of development of new models of care. Very briefly on the forced migration and health program at Mailman School of Public Health that's directed by Neil Boothby. Maybe Neil, you can raise your hand or say hello. That's Neil. And this program was founded in 1998 with support from the Mellon Foundation, and it's a leading center on humanitarian research and teaching. It's helped build a knowledge base improving humanitarian assistance around the world, and proudly can point to more than 400 of its graduates that are working all over the world in multiple countries engaged in humanitarian assistance and development work. So our engagement in terms of this region started firstly with a recognition, of course, of the importance of non-communicable disease in the Middle East and Turkey, with a small project that was started in 2013 to explore the importance of these issues in the region, because it's a leading cause of death and disability. And we also realized there was a potential to learn from a lot of ICAP's experience in tackling HIV/AIDS in sub-Saharan Africa, where one needs to develop a model of care that's focused on chronic disease, because HIV is a chronic infectious disease. And we felt that many of the lessons learned were quite relevant to trying to confront a chronic non-communicable disease. Very similar lessons learned. And then in terms of building on this, we had an Istanbul consultation in 2013, followed by a workshop at Amman in collaboration with the Columbia Center in Amman, and several faculty visits and student exchanges, and then an Istanbul panel that we participated in a few months ago. Building on this, we are now here to explore this idea of the changing health needs and complex emergencies, and largely to try to think about what are the policy implications based on these new needs for new generation of refugees. And the primary focus is on Syrian refugees in Turkey, Lebanon, and Jordan. And the focus is largely on how do we identify these changing health needs, what are the needs currently, and including chronic conditions, non-communicable disease, and what are the optimal ways to respond to these needs, and also what are the policy implications and changes in policy on a global level that are needed to facilitate the response to these needs. Oh, thank you. So what are kind of the priority questions as we embark on this workshop? I think there are many, but and tomorrow we'll start the day actually by going through some of objectives for this workshop, but also we will share with you some of the responses we received from all of you who were kind enough to participate in the survey that was sent out prior to this workshop. So the first question is, how can health systems adapt to the changing needs of refugees? And we've heard today many testimonials and descriptions of these changing needs in terms of chronic displacement, urbanization, and new health needs. Very importantly, what are the new training needs to achieve skilled workforce that's needed to meet those kinds of needs? Does the current workforce have the exact skills that are needed to respond to new challenging needs? That's an important question, and what are the training needs to achieve that? The third is, what are the policy implications for both host countries, but importantly for international agencies, as well as for relief organizations in this changing milieu of new refugees to situations. And lastly, what are the types of coalitions of stakeholders that are needed to address this critical humanitarian imperative? The stakeholders then include public health authorities, international agencies, academic institutions, NGOs, and many, many others. The need for new coalitions to be able to respond to some of the new needs.